today we're, as you have seen in the announcement, we're having a journal club on a paper and on the effectiveness of contraceptive counseling for women in the post-abortion period in study in Brazil. And Professor Yolanda Smith, whom you all most know very well, will be taking us through the journal club discussion. I know most of you know her through her role in leading research in CERT, but just to briefly introduce her, Professor Yolanda Smith is a professor of obstetrics and gynecology and a specialist in reproductive endocrinology and infertility at the University of Michigan. And she's also has been playing an instrumental role in the research capacity building efforts of CERT. So without saying much, I'll give the floor to Yolanda, but I'm going to be muting everyone from here so that we don't have too many echoes disturbing us. We going to be muting, and at every section when we are going to open it for discussion based on the assignments of each schools, we're going to unmute and then have you participate in the discussion so that it's easier to have a clear background of noise.
It starts here.
Yeah. No, please.
We can just share the PowerPoint only.
Nice job.
On this side you can see them, but not usually cannot.
Okay, hello everybody. Thank you so much for joining me this morning and this afternoon. We're going to be doing this journal club similar to the last one that we did. We're going to go through each section of this article that's focused on contraceptive counseling. We thought this would be an interesting topic to cover. And we'll stop at the end of each section and allow for a discussion. Each different institution has been assigned a section to pay some special attention to for discussion. So we're excited to hear what contributions and ideas people have. So in starting the review of this article on the effectiveness of contraceptive counseling for women in the post-abortive period and intervention study, the introduction starts talking about our gap in knowledge on this topic. They point out that 2/3 of abortions worldwide are from inadequate use of contraception or use of methods with high failure rates. They point out that the World Health Organization recommends contraceptive counseling to reduce unsafe abortions and maternal mortality. And the effectiveness of post-abortion contraceptive counseling has been shown in other studies, but they point out that programs in developing countries have been substandard in this area. In terms of the gap of knowledge, they also talk about personalized versus informational counseling as two different types of counseling. Personalized counseling they identify as counseling that motivates women to express and cope with concerns, feelings, and beliefs, as well as expectations around the topics such as contraception. I lost my slide. And personalized counseling also empowers women to make reproductive decisions. And they identify this as being different than informational counseling. So they point out that there are few randomized intervention trials of this personalized post-abortion contraceptive counseling that evaluate the effectiveness, especially in developing countries. This is the gap of knowledge that they identify. So the purpose of their study is to perform a randomized trial to assess the effectiveness of personalized post-abortion counseling on acceptability and use of contraceptive methods in low-income women in Brazil. They don't specifically state any hypothesis, but one can be inferred from their purpose. So from the introduction, I thought we'd talk about whether the background that they point out, whether that specifically points out the gap in knowledge and the question being asked. We're satisfied with that. Is the study purpose reasonable and clearly stated in their introduction? Is the randomized controlled trial comparison clearly stated? And is a hypothesis evident? So I will open this up for discussion now. We will unmute.
So any reflections from this section for introduction was assigned for Bahar Dar University and Addis Ababa University. I can definitely see Bahar Dar University has logged, you have joined. Are there any reflections on this, about the gap in knowledge, the purpose of the study, and the hypothesis of this article? I have unmuted Bahar Dar University. There's two. Yeah, go ahead. We can hear you. There are two Bahar Dar University. Okay. Maybe this. The first one, the first connection was lost for Bahar Dar.
Okay.
I think somebody was trying to respond.
Yeah, but that's the one which got disconnected.
Do we need to unmute somebody else to respond?
This probably we can kind of stop sharing and see, because we cannot see.
Okay, how do we do
where.
it?
Stop
Yeah.
sharing, I won't be able to see your slides.
Yeah, I mean, then we'll start sharing again. Just for the discussion, please, we can stop and then we can just click in here. Start sharing. You can also write on the chat box if there's other schools who want to respond, but I've tried to unmute the Bahar Dar OBGYN. And what's wrong? It says. Oh, this one is
Okay, they're talking.
that's what.
Bahar Dar.
Oh,
is
Bahar
talking
Dar? Which
on
one?
the top. You see,
Oh,
like on the
okay,
audio.
okay, on the audio. But Bahar Dar OBGYN is the other one here. But we can unmute them. I don't know why. Bahar Dar, the OBGYN, Bahar Dar BDU OBGYN, if you want to respond, can you unmute yourself? Because I could not unmute you from here. If it's a room.
Yeah, he's
Okay.
Yeah, I need it.
Yeah, it's unmute now. You can go ahead.
Good.
Any comments from Bahar Dar or join for free? Okay. You can give us a sign on your you can give us a sign. Hi Sol. Nice to see you.
Hi, hi, Lee, how are you? Hi, guys.
Well,
All right.
we'll,
What about the other?
any other comments from the other schools or CERT office?
Do people feel like they made a good argument for the study that they're going to do? Am I muted or can they hear me?
No,
Consider them lost.
Do you feel like the introduction gives you a good idea about what the comparison is going to be in this study? Okay. All right. So, so I would just say that I felt like I would have. This would be a really good point in the study to have said that this was going to be a randomized trial of personalized counseling versus group counseling, because that's really what this ended up being, and it would have been a really good place to really just point that out right at the beginning. So that would have clearly stating that at the beginning would have been, I think, an added strength that could have been in the study. But I thought they did a really good job in the background of pointing out the gap in knowledge, and that is really an important area to be studying. I think there are a lot of different hypotheses that could exist in this study, and that will be more evident as we see all the different endpoints.
If I can just add one point, though, they talk about if, it may seem like a very smooth point, but they talk about effectiveness in general. We're doing a randomized control trial, and then it's actually very good to be very explicit. It's gonna be efficacy study, relatively, not an effectiveness. So even if they're usually like in the title, and then even in the study design, probably efficacy probably maybe a better word to use.
Good point. All right, so let's move on. So again, this study is a randomized controlled trial of personalized counseling to group counseling. And in their methods, the setting was in a teaching hospital in northeast Brazil, a low-income area. They had 5 sites that were involved. This was done between 2008 and 2009. The population that they studied were women who were 1 to 2 weeks post their abortion and who were followed for 6 months. They did include minors with parental consent. They excluded women who underwent an abortion for a congenital anomaly or who had gestational trophoblastic disease or uterine tumors. They did randomization through a random numbers table that was generated by a statistician, and blinding included the blinding of the GYN who did the interviewing at time 0 initially prior to randomization, and who also did the interviewing at the 6-month follow-up. The women were also blinded to the group that they were enrolled in. Additionally, the way the study was run, that they did an interview initially that collected sociodemographic information, contraceptive knowledge, reproductive history, contraceptive use at the time of conception. They then randomized the women to one of those 2 groups, either the personalized counseling or the group counseling. They underwent that intervention by a provider that was trained. They then underwent a 3-month follow-up visit that was recommended, and then a 6-month follow-up interview that focused on their chosen contraceptive method. So in terms of the actual intervention that they did for the personalized comprehensive counseling, this was 30 minutes. There were 2 trained providers that did this counseling. It included 15 minutes of education and information that covered fertility after abortion, the ideal birth intervals, advantages and disadvantages of all contraceptives and their use, including emergency contraception. They did 10 minutes of provider-guided information based on the future plans of what they wanted to use, experience with their last method and their expectations about contraception, and talking about myths that they may have heard about contraception. And then the last 5 minutes of that 30-minute counseling was giving free provision of their chosen method and then verifying that they knew how to use it correctly. For the controls, the women who underwent the group counseling, this was a standard of care at their institution. This included 30 to 40-minute education with 20 to 25 women in a group. Counseling was done by specialized nursing staff. They had a discussion about contraceptive methods and side effects, and then there was a visit with gynecology and the supply of the method that was chosen, again at no cost. So they discussed their endpoints. Their primary endpoints were 4, contraceptive acceptability, this was yes or no, whether they chose a contraceptive or not, the chosen method, the use during the 6 months, whether they used it over the 6 months, yes or no, their compliance, whether they were using it correctly, and then secondary outcomes were satisfaction with the method, and whether they had another pregnancy during that 6 months. So the questions I want to bring up are, what do we think about the methods? Were they appropriate? Does the study seem like it will be generalizable? Do we think the outcome measures they were choosing were ideal? And any comments about the methodology, like randomization, blinding, the efforts to reduce bias, follow-up, those sort of things. So we'll go to the next groups.
So University of Gondar and McAley were assigned to this group, to the methodology, the study design and methods. So I can start with unmuting University of Gondar. Where is this?
Yeah, Gondar is here.
So I have unmuted Gondar. If you have.
Stop.
Oh, great, we have McKelly.
No, I haven't unmuted
No?
McAley.
Oh, not
It will
unmuted
be
yet.
the next, but I had unmuted Gondar. Okay. Is there any comment or feedback from Gondar?
Okay, there they are. Great.
Okay, then let's go to McAley. Okay, we'll give you time to think about it, and we'll go to McAley. I'll unmute McAley. McAley, you're on. Are there any comments on the questions posed by Dr. Yolanda on the method, on the research methods, the design? Any other outside of McAley or Gondar? If any of the, if you can give us a sign, we can unmute you.
What do people think about the blinding? Do you think that you can keep this kind of a study blinded?
Hi, Leah.
Hi, Munir.
How's everyone?
We're good. Thank you.
Okay, so I was thinking about, so I have read the article, and so my comment, can you hear me?
Yes,
Yes.
very well.
So my comment is like, so maybe something that we need to discuss also doing other times in doing research. So I see that there is no need to do this research for me because they compare the standardized care with 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 a new type of counseling. So what they are trying to achieve is the standard care is not a counseling. We know that counseling is one to one. So you can only give health education to people who are gathered, 20 to 30 people. So I don't think it's a type of counseling. By definition, it's not counseling. So it's a one to one communication is counseling. So what they did, the other arm, the control arm, is it's not even a very good counseling, but it is what it looks like a counseling. So for me, if someone has identified it as a problem, the quality of care of counseling is poor, it would have been better to do a quality improvement project whereby you try to improve the existing. I'm at home, so kids are going to cry. Sorry about that.
No, don't worry.
Okay, so for me, the standard care, if someone knows that the standard care is not good, you don't have to wait 6 months and to do a before and after study. Standard care is not enough. It's just from because there are tons of evidence that show that one-to-one counseling would improve women's acceptance of a better method of contraception, their adherence. There are other more evidences. So why? So if we can talk about this, especially if Yolanda can give her comment, I would be very happy. So why is there a need to do such a study? Would be for me is not something that I would do a study rather than I would try to improve the quality of care, which is a continuous process. That's why people who try to improve quality of care, they don't like us a before and after intervention because we just know what works and it's also different from place to place. So if you want to improve the quality of care, so we know what works in counseling. So this is one comment I have. The other comment I have is also the one care that they introduced, which is a kind of counseling, is also even an evidence-based counseling because you cannot start with education to do counseling. That would be for you giving too much information from condoms to sterilization, and that's a waste of time. So what we do currently is we just see what needs and assess our needs, and so we start from that point. So for me, the quality of care, what they have is not good, but also the intervention is not good, and I don't even see that there is a need to do a study just to see that counseling works because we know counseling works. So I'm done.
Thank you so much. That's very good reflection.
Oh, thank you for that. I mean, honestly, when we were looking for studies about counseling and that really described fully the counseling that they were providing and that were randomized trials of comparisons, we really found very few studies. So, I mean, I really felt like actually the data, the comparison data in a randomized fashion was actually pretty limited. So that was why we thought that this was worth presenting to the group.
Okay, but it will be very good then others would comment about the methodology and so on, which we can, it will be a very good educational thing to comment about the methodology and so on.
Yeah. So one of the things also I wanted to mention was they have 4 primary outcomes, which I think is usually pretty unusual. Usually there's one primary outcome and then many secondary outcomes, and you power your study to your primary outcome and kind of design your methods for your primary outcome. So I thought that was an unusual way to go about it, to have so many primary outcomes. And so that was another thing I thought was a little bit different about this study. Any other thoughts?
I mean, just to react to, Munir's idea about QI versus doing a randomized control trial. I think like Yolanda was saying, there is limited information from randomized controlled trials to demonstrate the efficacy of counseling. So, I mean, and then it has to be packaged in a way that you can actually demonstrate like a certain aspect of a counseling method is can be used in other settings. So, I mean, they mentioned in the background some observational studies, but there seems to be very limited information from clinical trials. And then it's actually through clinical trials, at least recommendations for evidence practice are suggested. That's probably why, I mean, we thought this would be a good paper to look at. But if it was a QI, I mean, the methodology would be very difficult, honestly, to demonstrate whether something is working. I mean, like it's a continuous, work. You would not be able to tell, which aspect. Like it's going to be a time varying variable, so it's very difficult to demonstrate methodology.
Yeah, I'd say in terms of this also being able to lead into a QA project, they did not really collect many variables about how the patients, about how this worked within the system, or about how the patients felt about it, or what they thought was beneficial within the counseling. They only collected are you satisfied with it at the end, and that was really about their contraceptive method rather than anything about the counseling. So they didn't really collect the kind of variables that would actually be helpful towards a QA improvement project later, which is too bad.
But in general, I mean, I definitely see Munir's point about the standard of care not being an appropriate method. But if that was the standard of care they had, I guess to get a strong evidence to shift to the one-to-one counseling, which may impact their service in terms of needing more resources and so on. I think to get that kind of evidence, it may be a good way to have that kind of study. I think that's one of the values I see, because if that's already the standard of care, and having a stronger randomized trial versus just introducing a QI project may generate more evidence to allocate the resources.
Yeah, certainly it's going to take more changes within the clinic flow and within personnel that have to be hired to be able to carry out counseling in that fashion.
Yeah. And
having some data that supports that compared to what you're currently doing, provides some level of research support for moving to that direction. All right, let's move on. All right, so next slide.
That didn't come up yet.
Oh, okay.
So no, it didn't start showing. Maybe I have to press it again.
So for their statistics, their power analysis was based on expecting a 20% difference in one of the primary endpoints, which was use of contraception. They expected this to be 50% in the personal counseling versus 30% in the group counseling. With a power of 80%, type 1 error is 0.05. The recruitment goal was 246. That would be 123 in each group. They were going to do an intention to treat analysis, chi-square to compare frequency of primary and secondary outcomes among the groups, and then rate risk to estimate the magnitude of intervention effect on their outcomes. So for the statistics, our questions to bring up were, does the power analysis seem reasonable? Is a 20% difference meaningful? Are they accounting for dropouts? Are they accounting, does their power analysis account for their other endpoints? And does their statistical plan address their questions being asked? So let's see, who is going to, do we have commenting on statistics?
No, we're still in the design.
Okay.
Still, yeah.
So any comments about statistics?
Any comments from anywhere, Makale, Gondar, or others?
Do we think a 20% difference would be meaningful? Is that a reasonable?
Haramaya?
Yes.
Okay.
Abil.
Dr. Abil?
You need to unmute him.
I haven't unmuted. Wait, give me 1 second. Okay, you're unmuted now.
Can you hear me?
We can hear you.
Yeah, we can hear you.
Well,
Yeah, the 20% difference may be acceptable, but the prevalence, which was taken 50% and 30%, where is it taken? Is it from the baseline data? And it will decrease the total sample size. So the difference, making 20% and 20% difference may be acceptable. But how is 50% and 30% of patient?
right, I don't think they gave a,
There's actually a paper, like reference 8. I didn't look at that.
yeah.
Probably for the control group, they're looking at the 30% from that.
Yeah, so I think they had some data to support using that difference for that one outcome, but they don't really point out whether the power, whether their sample size is going to meet any of their other primary endpoints. They don't tell you how much, whether, what kind of difference they're going to be able to identify in their other outcomes.
Yeah, so I mean, like Yolanda, you said there were 4 outcomes. So now at least we are inferring, like, at least their primary outcome. They're looking at, like, in terms of design and to be able to calculate the sample size is use of contraceptive methods 6 months later. So that's how they powered it. But I actually did a power calculation and yes, and it's I mean, like, I used like at least 2 software to look at it, like, because I mean, this is based on a chi-square test, looking at 2 independent groups. Like, we have a prevalence P, like, 2 proportions. We're comparing 2 proportions, P1, 30% and 50%. And by that, I mean, like, if they're not accounting for other, like, dropouts and stuff like that, this seems like, 91 in each group seems to be adequate. 91 in each group.
Okay. All right. So from what you're saying, they had more than they.
Yes. Yeah.
Yeah. Yes, please.
Go ahead, Dr. Abil. Yeah,
Yes.
Go ahead, Dr. Abil.
So the primary outcome is contraceptive acceptance. Contraceptive acceptance.
Acceptable.
Can you?
That's one right?
Can you? Yeah. So the contraceptive acceptability. Yes, acceptable. So sample size should be calculated from the primary outcome. Yes, from the endpoint's primary outcome. But here they calculate the sample size whether they give counseling or not, assuming that 50% of them will be counseled.
Would be okay. Yeah, their wording that they used was often confusing, and the way I interpreted acceptability was if somebody walked out of the counseling session with contraception in their hand, that's what they called acceptability. I'm not 100% sure that that's what they meant, but that's how I ended up interpreting it. But it was difficult to interpret. I had to read it a few times to come up with
I think that's the kind of interpretation, because it says following up, at least we're jumping to the result. It says at the end of the 6 months, they continued using it. So it seems like, they have already been given the contraceptive method.
But that's another primary. They had multiple primary
Yes.
outcomes. So the acceptability was the initial acceptability, right? Just after the counseling, the acceptability.
Yes.
And I think his Abel's question is, for the sample size calculation, they should have used the acceptability rate rather than the compliance.
I mean, it seems like they opted to use the use after 6 months,
After
but
6 months,
they can
yeah.
also think of using a composite outcome. So they,
And they
Yeah.
didn't have just one primary outcome, maybe,
Four,
so
at
they
least
just
four.
chose one of the primary outcomes. That was one of the comments, yeah.
Yeah. And luckily they had enough, but they did not account for dropouts either in their power analysis. All right, well, let's keep going. Okay, so this is a diagram of their study design. You can see that they had 310 women that they assessed for eligibility. They excluded 64, and then another 25 did not meet inclusion criteria, and 39 did not want to participate, so they randomized 246. And then along the way, they lost 0 to follow-up in the personalized counseling, and they had 123 to analyze. And in the group counseling, out of those women, 119 did walk out of the counseling session with contraception in their hand. So that would be the ones that considered it acceptable. And they had 4 of those 119 that were lost to follow-up, and then 55 who discontinued the intervention, so stopped their contraception. And they did analyze all of the women in that group as well, all the women in their intent to treat analysis. So this is table 1, their sociodemographic table, basically showing that they had good randomization, as there were no variables that were different between the groups. They lived in the same areas, age was similar, around 26, 27, same number of years of education, same percentage were employed, cohabiting, about 25 to 30% had had a previous abortion, and they had approximately 1 child at home, but equally distributed variables. Table 2 for their results, this is the acceptance. So this, as well as the use and then the correct use. So acceptance, my understanding is this is you walk out of the counseling session with contraception in your hand, and then they had use after 6 months, and then they also looked at whether they were using it correctly at 6 months. So in the first line, we can see that out of the intervention group, 100% walked out with a contraceptive, and in the control group, 96.7% walked out with a contraceptive, so that was no different. So they had equal acceptance of contraception. After 6 months in the intervention group, 98% were still using a contraceptive, and in the control group, 70% were still using a contraceptive. So there was a decrease of contraceptive use among the control group. That was significantly different. And then in looking at correct use, in the intervention group, it was 98.4% were using it correctly, and in the control group, 55% were using their contraceptive correctly, and that was also statistically different. And then they also looked at the method chosen. So the methods.
ዲፓርትመንቱ ይቅርታ ይበለው የሚባል አሰራር ህግ የለም ገብቷል።
The methods were oral contraceptives, monthly injection, quarterly injection, condom, and IUD. So there was very little IUD use in general, very little LARC use in general. You can see the quarterly injectable was significantly more utilized in the intervention group with 41% compared to 8% in the control group. That was statistically different. And condoms were more commonly used in the control group at 19.5% compared to the intervention group. And that was statistically different. Oral contraceptives and monthly injectables were not statistically different. And then for the satisfaction questionnaire, you can see that in the intervention group, 80% were very satisfied with their contraceptive at the end of 6 months, compared to 33% in the control group. That was significantly different. And in the control group, they were more likely to be satisfied or dissatisfied compared to the intervention group. They also looked at pregnancy, and overall, there was a 5.7% pregnancy rate in the 6-month follow-up. This was 1.6% in the intervention group and 9.7% in the control group. That was statistically different. So there was a significant reduction in pregnancy rate in the intervention group. So for the results, I thought we'd talk about, is a primary question answered by this research? And were the results presented in a way that was logical and understandable? And was there any other data or analyses that would have enhanced the research?
Can you mute? Okay.
I will stop sharing this.
Okay. So, are there any comments from Juma University or St. Paul's on the results that was just discussed and based on your review of the article? Juma, I can just unmute Juma first.
Juma. Yeah, okay. Juma has joined after a lot of struggle with network. My colleague here is Birru from the midwifery department, and some of my colleagues are also running here and there look for network. So we are watching, spitting through mobile network. No more.
Oh.
So I will give the chance to Mr. Birru.
Okay.
Okay, thank you very much. I'm officer from midwifery department. I've article published on 2011 on acceptability of
You can turn off the video.
And the question of this research.
You can turn off the video so that we can hear
more
better.
Okay, audio.
Yeah, just turn off the video so that we can hear better as usual. And then with the audio we can hear.
Okay, can I start now?
Yeah, go ahead.
Can I start?
Yes.
Can I start now?
Yes.
Okay, I have seen all articles Okay, as to me, these articles answer the research questions, which is this interventional study to compare the effectiveness of personalized counseling on to prevent unintended pregnancy or to prevent abortion, unnecessary abortion, which is caused major maternity maternal disease. So I think article question of there is the primary goal of this research is to answer the difference between standard counseling method, which is generalized, or in-group counseling, which is normally and in different hospitals in the same way in our Ethiopians. The paper is in Brazil. The so different standard letters, which by grouping different patients. But this research try to compare personalized or individualized counseling, which is better than group. So the result shows there are different statistically significant results, which is shows the better, which is this individualized or personal counseling better than this standard, which is a counseling which is undergone with groups by having 20 to 25 clients together. So this is result answers the question, which is try to compare the intervention group and with control groups. So to me, this this research try to answer or the research question.
Okay. Thank you.
Thank you.
Thank you for your comment. Any other comment from others on the results? I think the one which saw St. Paul is Solomon. So, is there any other comment from the CERT team?
From us?
No. I'm moving to the other schools.
Haramaya was actually
Yeah.
raising their Haramaya.
Okay, Haramaya, Dr. Abel, I've unmuted you, and then I'll give to the CERT office. I think the CERT office.
Okay, again, so when the primary endpoint was taken it's acceptance of contraception. It is not significantly associated. It is not significant.
Yes, acceptance
So
is
when
not
you see table on acceptance, it is not significantly associated. And the rate risk is 1.06, which is 3%. 3% rate risk. Otherwise, using after 6 months, correcting after 6 months is significantly associated. Which means the initial sample size calculation was not correct because the sample size is calculated for acceptance. What significantly associated are those variables for whom sample size is not calculated. So I think the sample is not proper enough to measure acceptance. It will be acceptable to take a 20%, but the 20% difference can be obtained from 86, which is 80% from the individual counseling, 60% from the control. So this also increase the sample size so that the result will measure what's calculated for sample size. This is my comment.
I don't think everyone we have, but
I think
We'll again reflect what you said. Burhan will reflect because
the way I thought I heard it. So, Dr. Abil is saying, looking at the three outcomes on table 2, the difference in the acceptance rate, the proportion of acceptance between the control and the intervention group is 3%, and it's not statistically significant. But when you look at use after 6 months, statistically significant. Even if you did not use the term, it's actually 40. There is a 41% difference. And Dr. Abil is making the argument the sample size was not calculated based on the acceptance. I think that we actually bear that out. But once we already decide, about sample size, we can't go back to look at it again to talk about whether this was a legitimate thing. I mean, you already, by design, you already have gone through that. What we can say is, if they're using the second outcome, which is use after 6 months, and they're looking at a 20% difference, it's actually, they were able to pick that up. It's 41%, and it's also significantly associated. So we can talk about sample size at this point, honestly, once we're into the results section. But yeah, like you summarized it, and the same thing about correct use.
And I think at some point they also kind of make an argument in the discussion saying acceptance was higher.
Yeah, in the discussion, yes. Yeah,
which was not the case. Yeah.
I have one minor comment.
Yeah.
Yeah, in terms of, so there are some unconventional terminology that they use. I'm not sure, maybe you graduated recently, so you remember, there is, I don't know of any, term called rate risk. So what we're calculating is. So
say it again.
Yeah. So I'm talking about the calculation of the rate risk. Terminologically, what we're having is proportions. We're looking at proportions, so meaning risks. We can talk about risks. So probably if they're meaning relative risk, that's probably is a better term. Or rate and risk, they go or we can have incidence rate ratio, or risk ratio. So that's a little bit misleading. It's not appropriate terminology, at least in epidemiology. Yes, yeah.
If you had that term before, risk ratio is usually the relative risk. Yeah.
I was looking it up.
All right. Let's go to. Okay, so I have to.
I also found myself wondering about stratification of the secondary variables or secondary outcomes depending on different method of contraception, which I don't know if that's anything, but.
Yeah, so you mean if they were doing the quarterly injection, were they more likely to
be satisfied
or
continue. Get pregnant?
Yeah,
right.
Okay, so for the discussion, they talked about the individual counseling and said that there was greater acceptance and use of contraception and correct use in the first 6 months following an abortion. I think we've already talked about that and how there really was not greater acceptance that was equal between the two groups. They said that with individual counseling, you're more likely to use long-acting contraceptive methods. Of course, they really didn't have much IUD use, but they did have more quarterly injections. The women with individualized counseling were more satisfied with the chosen method. There were less chance of pregnancy as well. And they felt that this agrees with observational studies on counseling and free contraception post-abortion to reduce pregnancy. In talking about the study conduct and comparison, They felt that the randomization was appropriate based on their sociodemographics, that those were equal between the two groups, and they felt that their dropout rate was lower than other studies, and it really was quite low, with no dropout rates in the intervention group, and I think there was 4 that dropped out of the control group. They talked about adherence to contraceptive use being impacted by the intervention, and that this has varied among previous studies. They felt that factors suggested as contributing to the intervention effectiveness included the population that was targeted. They felt it was a motivated population, the counseling time, that there was more time in the post-abortal period, the content and quality of the personalized counseling, that they had updated their materials and things like that. The providers, that these were providers that were all received training prior, and that they had free contraceptives. That was an important part of the contraceptive counseling. They talked about the contraceptives chosen, and that there were few IUDs, and that they felt this may reflect lack of provider knowledge rather than necessarily what patients might select. And that there was a higher satisfaction in intervention group, and this suggests that the intervention increases their satisfaction in relation to the chosen method. They're happy, in other words, they're happy with the method, and therefore they continue to use it, and therefore they're highly satisfied. They talk about the limitations, that the follow-up time was only 6 months, that their measurement of effectiveness was their acceptance rate and use, and these were selected because it took less time and cost for the follow-up. They said that unwanted pregnancy would be a more reliable effectiveness measure, but that intention changes, and this was difficult to measure, and therefore they went with the outcomes that they used. They pointed out that this was just one city in Brazil and may not provide generalizability. So, in terms of the discussion, things I thought we could talk about is whether you agree with the interpretation of the results. Was there greater acceptance? Was there more long-acting contraceptive use? They talked about, in the discussion, about increasing condom use. What do people think about that? Are there other areas you'd like to see addressed? Is there important literature that wasn't covered? Were there any other limitations that people think should have been mentioned?
Okay, so any comments from being, it was assigned to Adama and Deborah Tabor, but I don't think we have. But any yes, Dr. Oh, you have Deborah Tabor is here? Lalem, okay. Deborah Tabor, you're on. If you have any comments. On the discussion, what do you think of the points that Yolanda just raised?
What do people think about the factors that they listed as contributing to the effectiveness of the intervention?